It's 5 minutes past the hour, and I'd like to welcome everybody to this, our second Delivering Men's Health webinar. My name's Anthony Brown. I'm the Chair of Global Action on Men's Health, and I'd like to welcome everybody today. As you can probably tell from my background, I'm located in Sydney, Australia, and we're really glad to be joined by colleagues from around the world. In Australia, it's a tradition to start our meetings and to start an informal occasion by an acknowledgement that we're situated on the lands of traditional Aboriginal and Torres Strait Islander people, and I'm on the land of the Gadigal people, and people might know that as Eastern Sydney from people who aren't from Australia. But I'd like to acknowledge that, and acknowledge the traditional lands from wherever people are coming to us from, and acknowledge and welcome any First Nations people who may be joining us today. So this, as I said, is the second of our webinars on delivering men's health, and because we want to share the learnings from two things, from our Delivering Men's Health report we published in September, and to learn from colleagues from around the world about work that they've been doing that has successfully engaged men effectively in health services and other services, and to share some examples of good practice. We held a webinar in September that had a focus on men's health policy, and this one today is on practice. And we're really excited and pleased that we'll be joined today by Kira Fortune from the World Health Organization's Western Pacific Regional Office. We'll be talking about some of the work that we're doing in partnership with them around men's health and what their men's health plans for the regions are. You can see today that this is our program and the great speakers who'll be joining us. We have people who are joining us from Asia and Oceania, and we've particularly chosen this time of day because we knew it was a time that was better when colleagues in this region will be able to join us. These are the great speakers we've got lined up today, and I remind all the speakers to please keep to 10 minutes, and I will be keeping you on time. I know that we've got so much to share, and 10 minutes doesn't seem like enough time to get across all the great things you're doing, but we'll have time for discussions and questions after your presentation. So just the next slide, please, Peter, and thank you for that. So the webinar will aim to last for about 90 minutes, and as I said, I will be keeping us to time. I ask people, if you're not speaking, if you're not a speaker, to please keep mute, because we can hear background noise. And we've got a number of people joining us today. We expected about 80 people to join us from our registrations from around the world, which is just fantastic. And so we ask people to please keep your microphone off. Please ask any questions or make any comments using the chat function. We'll be monitoring that, and we'll be using that to ask questions in the question and answer section at the end of the program. But I can see people are doing it already. Invite people to please say hello and introduce yourself during the chat. And yes, ask questions in the chat, but we can also use it to make any comments or suggestions, or share any relevant resources or website you might know about as we go through. So this webinar series is a joint presentation between Global Action on Men's Health and the International Journal on Men's Social and Community Health. And the International Journal is the official journal of Global Action. And we're really pleased today to welcome Steve Robinson, the editor of the International Journal on Men's Social and Community Health, to give us a few words of welcome as well, and to let us know about the journal. So we'll kick off by going over to you, Steve.
Great, thanks for that. Yeah, I'll only take 2 minutes of your time just to say a little bit about the journal. So the journal's been going now for just over 3 years, coming up to 4 years. And in that time, the editorial team have worked really hard to get the journal included in Scopus, which most of you will know is one of the largest abstract and citation databases. The next step for us, hopefully, is to continue to progress and work towards getting an impact factor in the next couple of years. And if you want to take a look at the journal, there's some absolutely fabulous stuff there. There's a few special issues, for example. There's one around men's health policy. There's a special issue around intersectionality and men's health disparities, but also lots of other really interesting articles. And my ask today is 2 things. Please do visit the site, make use of the articles. It's an open access journal. And my other plea is that we are looking for copy, and it's difficult sometimes to get copy when you're not impact factor rated. So if anyone has papers that are looking for a home, then please do consider the journal and consider passing that offer on to people like your PhD students and others. We are also interested in practice-based articles. So for those of you that are working in practice, we're interested in that sort of paper as well. So please do take a look and think about submission. I think that's it. Thanks, Anthony and Peter.
Thank you so much, Steve. As I said, the journal is the official journal of global action. We're very proud to be associated with it, and really thrilled that with this joint webinar series. Another good reason to encourage people to publish in the journal is that we use opportunities like this to actually promote some of the great work that's published in there. And which leads me to introduce our first speaker, Michael Whitehead. Michael's work was published last year in the journal, and we reached out to Michael and invited him to be part of today. The starting point for that connection was the article published in the journal. So Michael works at St Vincent's Hospital in Sydney, where he's the men's health clinical nurse consultant. And I'd hazard a guess to say that Michael would be one of the few men's health clinical nurse consultants in Australia. Michael's currently the clinical lead for St Vincent's Men's Health Centre, which will be launched early next year. So that's really exciting news. And I invite Michael to please take us through the findings of your work around men's health promotion in waiting rooms. So thank you, Michael, and welcome.
Great, thank you, Anthony. So this paper was published in February of this year in the International Journal of Men's Social and Community Health. Next slide, thanks, Peter. So this presentation I'm doing today is attended on the country of the Darug and the Gundungurra peoples, and I pay respect to traditional owners past, present and emerging, and I acknowledge and respect the First Nation traditional owners, custodians and elders throughout Australia and recognise their several sovereign connections to land, water and culture. Peter, next slide please. So just for context, this is just a few facts and figures about Australian and Australian males. So Australian males make up just under half of the country's population. The life expectancy for Aboriginal and Torres Strait Islander men is about 10 years lower than non-Indigenous men. Go back, Peter. Yeah. Homelessness rates are higher for males in Australia than females. Death by suicide, is over 3 times more common. For males versus females, are much more common for our Aboriginal and Torres Strait Islander brothers. 3 in 4 men are overweight or obese in Australia, which is 20% greater than females, and over 80% of Australian men have visited a GP in the past 12 months. Next slide, thanks, Pete. So this study aimed to observe the gendered orientation of printed health promotional material and health facility waiting rooms within a single New South Wales local government area. And it was a prospective observational study which audited all of these printed materials. So in total, 24 sites were surveyed, general practice centres at 19, community health centres 3, and hospitals at 2. Thanks, Pete. So the results that there were 1,143 health promotional materials audited over these sites. About 3% were male specific, 15% were female specific, and just over 81% were gender neutral. So the gendered focus was overwhelmingly female to male with a ratio of approximately 5:1, and no transgender or non-binary specific health literature was identified in these sites. Thanks, Pete. So it just brought us to our discussion. So the first point was that targeted male health promotion has utility. And we see that in Australia in particular through the Men's Shed movement, which has spread globally from here, and also in the UK with certain football mental health initiatives. We can see that when a gendered lens is applied through health promotion, that there is uptake, and that has been established now across quite a few settings. The second discussion point was the generalisation of health promotion. So it's just a quote here from the UN and the World Health Organization that says sex and gender are increasingly recognised as important determinants of health for women and for men. And that was back in 2010, so some time ago that was clearly recognised. And so it brought us to the question of, is health promotion ignoring gender as a determinant of health in respect to the findings of our study here? So the third point is, what did we actually find? So what we're seeing in this study is the 3% of promotions that were men specific were mental health, and also prostate cancer literature, which is very encouraging. However, what was not seen in any of our settings was chronic disease or non-communicable disease promotions such as coronary vascular disease, diabetes, stroke, or COPD, which is quite interesting, particularly within this pandemic landscape where we see a triangulation of sorts between gender, comorbidities, and also death and hospitalisation. And the fourth point we discuss is the changing face of health advertising. So the pivoting to different and emerging promotional modes for boys and men versus traditional modes. Next slide. Thanks, Pete. So the conclusions of our paper and some future approaches to consider is that this research highlighted that despite the known outcomes of male mortality and morbidity, male-specific literature is significantly underrepresented within health spaces. So these are health spaces that we as clinicians control ourselves. So some future approaches that was discussed in the paper, and I'm sure we'll be discussing throughout this talk, is that there is a clear need for sex and gender-based focused promotions. And the example I gave earlier was, say, with men's sheds. Looking at also promotional modalities. So how do we appeal to different age groups, different men's in different settings? We know we don't like to be, put a stereotypical lens across men. We want to be quite nuanced in our approach. So how do we do that without having a blanket approach that doesn't really say much to anyone in particular? And some of the examples we got were, say, posters within health facility waiting rooms saying, get your blood pressure checked. That's all it basically said. It didn't target anyone. And we know that when we look at targeting particular groups or particular cultures or ethnicities or people from different backgrounds, we use quite specific language. We use iconography, we use imagery. But what we're seeing within health facility waiting rooms, certainly within this study, is that there was almost quite a blank canvas. Just a message was given and nothing else to support it. And we think that is quite vital when you are trying to reach a cohort of people who traditionally don't engage with health as much as women do. And the third point we wanted to look at is looking at partnerships. So partnerships between kind of the micro level and the macro level. So we're looking at, yes, within men's health, there are quite a few community grassroots organisations. There are clinicians such as myself, where we sit within the kind of hospital sphere, that are doing new and innovative approaches for men's health. But then how do we reach up beyond that to meet with key government officials, key health organisations, and kind of bridge that gap first, because we love to have their reinforcing sponsorship behind us. And part of the challenge that we have working in health is to get programs that are validated, that have been shown to have utility, and try and roll them out successfully across the health landscape. Thank you, Peter. And that's just my presentation wrapped up, so I could be contacted on those means. But thank you very much for your time.
That's fantastic. Thank you so much, Michael, and thank you especially for keeping to time, which has given us a little bit more time that we can use in our questions. There's a link to the wonderful article that Michael and his colleagues wrote in the chat, and I'd encourage people to have a look at that as well. I'd now like to introduce our next speaker, Dr. Zach Seidler, who's known to many people, or at least many of the Australians who are on the call. Zach's a clinical psychologist and the director of mental health training at Movember, and he's also a senior research fellow at always mispronounce, Oregon, at the University of Melbourne. Zach has devoted several years to the goal of reducing the staggering male suicide rate through treating and researching men's mental health, with over 50 peer-reviewed articles that he's published. Zach's a member of the Advisory Committee for White Ribbon, and also the National Mental Health Commission and Suicide Prevention Australia. So welcome and thank you, Zach.
Thanks a lot, and thank you for Michael for giving me an extra minute, because I'm going to need it, no doubt.
You don't have an extra minute.
Oh no, come on! It's Monday. It's a Monday. I've just been doing multiple 2-hour webinars today, so it's going to be good to do this in 10 minutes instead. I like a bit of speed talking. Love a challenge. It's lovely to be here. I'm also coming to you from Gadigal land in Sydney, Australia, and so nice to see so many familiar faces with all of my men's health friends on here. A couple of Twitter friends who I've never seen their faces before, so that's always enjoyable to catch up. I'm obviously coming to you with this hairy upper lip because I work at Movember, who many of you have been in contact with and helped us out in previous years and currently as well. So thank you for that. It's a big time of year for men's health and mental health, and I think we're all going from strength to strength as a field, and it's lovely to have this sense of community and connection with all of you as well. So thank you in advance for all of the support that we've had, and looking forward to working and collaborating with you all in future. So I'm going to talk very quickly about one of our programs that I lead at Movember, that's funded by Movember, which is called Men in Mind. So we obviously know the stats; they're pretty dire when it comes to male suicide, especially in the Western world, and we are doing our best to attempt to change this day-to-day, which is where we're losing about 7 men a day in Australia to suicide prematurely. Something that's really, really important, and that I try to draw people's attention to, is the fact that while this black line of men seeking help continues to grow, and it's in an upwards trending trajectory, that's thanks to all of you and all of the organisations out there that are pumping men into services. Nonetheless, the male suicide rate in Australia, at least with the purple line, continues to rise as well, and we see we have a bit of an idea, I guess, in our heads stereotypically that if men go in and seek help, whether that be through medication with a GP or a psychiatrist, or through psychotherapy with someone like myself, that it's the panacea and all will be well. If we just get them in the door, everything will be fine. And what I kind of sold to Movember before I began is that you cannot continue to tell men to talk more, to open up more, to reach out if they are not being catered for, if they're not getting what they want and what they need on the other end. And what became increasingly clear is that men are not getting what they need, but they are within our reach. And this stereotype that men are not seeking help is bullshit, frankly. It is clearly not the case. And it's very hard to come into contact with a man who is in crisis, who is not in touch with our mental health system in one way or another. And it is nonetheless failing many of them. And the clearest way of showing this is that over 65% of men who suicided sought help in the year prior. And so they are in contact with our system. They are within our waiting rooms. They are seeing people like myself, and they're still slipping through the cracks. And I think that if we are going to sell these men help seeking, we may as well make sure that it actually is hitting the spot. I ran a study with my group, and lots of my collaborators are going to be familiar to you in John Olaf and John Ogrodnishuk and Simon Rice, Kylie King, a couple of names there. And we surveyed 2,000 guys last year at the beginning of COVID. So no one had anything else to do, so they filled out our survey, which was very kind of them. And what we found is that we went down the help seeking route. We wanted to speak to guys who had been in therapy, because lots of people are just talking hypothetically about if you were to seek help. We wanted to speak to guys who are. And what we found is that 43% of them had dropped out prematurely without informing their clinician, and 25% of those had never sought help again. That is really, really problematic. And when we started to ask them, we went further and we asked them, what are the reasons for this? Because often these statistics are just reported from the clinician's point of view rather than the men themselves. And we found that rather than what is perceived to be the case amongst clinicians, at least, which is that, oh no, they had their problems resolved. They just got over it and they left. Actually, we found that the connection with counsellor was the serious issue that led them to drop out prematurely, in that they didn't feel that they were understood, heard, or responded to in a way that seemed to be male-friendly, that seemed to be, in a way that made sense to them, that they felt they could be open and honest with them. And so the really warming and empowering side of this is that while the inconvenience, for instance, or the expense is something that is largely out of your everyday clinician's control, because they have to make a living, and it's, there are rates and there are certain opening hours, and all of these things, exist as barriers. But the one thing that we really do have within our control is how we connect with these men, is how we understand them, is what our attitudes and beliefs and biases are when it comes to men and masculinity, when it comes to our training around how to go about engaging with men. That is something that we can do the work for, to make sure that these men, the onus isn't on them to fit within our system. If for too long that has been the case, that men have been forced into a box, and clinicians have gone, you have to work to my mold rather than vice versa. It's about time that the system adapts to men. I also did this study last year, which was a pretty simple model, just showing that the worse his experience in previous therapy, the more doubts he has that it could ever help him again, and the less likely he is to disclose future distress to his GP. Now, that's really, really problematic, because these guys there's so many barriers to them getting in the first place, that when they are in there, if they have an unsatisfying experience, that prognostic pessimism starts to come into play. And when we get into the non-disclosure in future, that's where suicidality and shame and stigma start to really coalesce, and it's very, very dangerous. And that's when we get men slipping through the cracks. So I think that there is a very short window of opportunity, and it's not to stress out clinicians, but it is to say that if we talk about this stuff, if we understand and expect that we're going to have to do a lot of relationship building early on in order to get these men to invest, I think we can do a much better job. So what needs to change? Well, in my eyes, we're doing a lot more of, we need more. And there's no doubt when it comes to the fact that we don't have enough beds, we don't have enough clinicians. That is all true. But I think it's kind of pulling our attention away from the what, which is to say that our mental health system on the whole was kind of built in a very, piecemeal fashion early on in the 20th century. And I think that we really need to start to pull it apart and go, what are we actually offering here, and is it working, rather than just adding more money into a system that's potentially broken. So I'm starting to question, what is this system, and does it cater to men? Does it actually provide them with what they want? And so I spend most of my days speaking with guys, interviewing clinicians, creating interventions that are going to respond to an adaptation, a tailoring of our mental health services that actually hit the mark. So very quickly, we ran this other study that was looking at myths, and pretty clearly these stereotypes are just really, really problematic amongst clinicians, amongst men, amongst our community, which is to say that everyone thinks men don't want to seek help, that they're ashamed to go to therapy, that they won't attend of their own accord, that they only want to see male clinicians. None of this is true. And I'm not sure where any of these anecdotes came from, and it's about time we get rid of them. So we need to stop assuming and start asking. And I'm really, really hoping to push a very, consumer-led, client-centered way of going about male mental health from now on, where men are central in co-design of interventions, in co-design of what therapy looks like, and service provision as well. So what are we doing about it? Well, this is where my training comes into play. I figured pretty early on in my career that there's enough people trying to mold men. It's about time that the services get their day in the sun. And so I created this training program called Men in Mind, which is going to upskill therapists. They ran a curricular review of all of the mental health and medical curricula in Australia, and no one is talking about gender or mental health, none of them, across Australia, which I thought was very problematic. So we've created an online training program. It runs for about 10 hours. There are 5 modules. It works through the basics of masculinity all the way into, suicide intervention for men. It talks about depression, obviously, and how that manifests differently. And I know that many of you have worked in that space, and specifically in the engagement space around how to go about motivating men in therapy as well. And we've got 40 or so vignette videos with incredible actors. And this is, again, thanks to Movember, to have the time and the funds to put towards creating something that actually looks good and is engaging as well. We've got note-taking exercises and print-out worksheets as well. And it's thankfully after our RCT, which is taking place next year, because we have, again, the time and the ability to do that, it's going to be rolled out globally across our Movember markets. So obviously, we're all here to help ensure all men live happier, healthier, longer lives, but we're really only getting started. And I think there's a really long way ahead, but it's great to be in this space, and very thankful to have been able to speak with you all today. So thank you.
Thank you so much, Zach, for that wonderful presentation. You only went 30 seconds over time, so that's fine. Excellent.
I've done worse.
Didn't need the. And my day job, when I'm not chair of Global Action, is actually working in the consumer advocacy space and working with patients in co-design. And it, my heart sings when I hear you saying we need to involve men more, because men are so often invisible when we talk about people's lived experience, and the lived experience of men of illness and using health services, especially in mental health, but not just in mental health, is something that I think we really need to focus on. So thank you so much for starting that discussion with us today. Now I'd like to welcome Dr. Chin Hai, who has been working in the field of men's health since 2013, when he published the first Asian men's health report with his team in Malaysia. Recognising the gaps in men's health, he subsequently embarked on his PhD with the aim to improve men's health, specifically using digital technology, which is another area that he's passionate about. He's developed and evaluated the Screenmen web app, which aims to improve health screening uptake in men. Besides that, he's also developed online training modules for doctors to manage men's health, and was involved with the Ministry of Health in the development of the National Men's Health Plan of Action for Malaysia. So welcome, Dr. Chin Hai. We're very interested to hear a bit more, to learn more about Screenmen, and welcome and thank you.
Well, thanks so much, Anthony, for the introduction. So I was asked by Peter again. Thanks to Peter for inviting me to share my work on men's health and digital health. So I was asked to actually share what we are doing in terms of digital health for men's health. I'm sure all of you have done quite a lot of digital health projects too, just like Zach has developed online modules to train people about mental health. So here I am today just to share quickly about a project on health screening in men. Okay, so the app, the web app we have developed is actually called Screenmen. Okay, here is how it looks like. It is actually a mobile web app that educates, motivates, and empowers men to undergo evidence-based health screening. So I think all of you must already be aware about this. Health screening, early detection with optimized treatment reduces burden, monetary burden, reduces loss of national productivity, and most importantly, it improves men's quality of life as well as their families in terms of social economy as well as psychology. So I think globally is quite the same. In Malaysia as well, the uptake of screening is low, especially in men. Even there's a program, social security organization in Malaysia, they provide free screening to men and women, and the uptake is still very bad, especially in men, even though it's free. Okay, so looking at this data, I just want to share with everyone. This is a national data, National Health and Mobility Survey done by the government. So as you can see, the blue bars are actually reflect the prevalence of people who do not know that they have hypertension. And as compared to the red one means the prevalence of people who have hypertension. So it shows that a lot of people do not have hypertension, especially as you look at the line here, below the age of 55, there are more people who doesn't know. The blue bar is higher than the red bar. And as you go younger and younger, the gap got wider and wider. So it's just sad that we are looking at the young people, and when they grow to 40 years old and they got all the diseases coming in. So which is why brought us to Screenmen, this project. We want to help them catch the problem because it's too late. So besides the screening of the diseases data, it's also a fact that now everyone have access, mostly everyone, I think, maybe at least 90% of Malaysians now have access to the internet. Most of the people have smartphone in Malaysia, and they spend about 3 hours of the time on the mobile devices every day. And various studies have shown that mobile health can improve the health of the public. Okay, so based on that reason, we embarked to develop the Screenmen. We use this UKMRC complex intervention framework, where we use theories, evidence, and we explore the needs of the people on the ground before we develop the Screenmen. So there are a lot of things, but I'm just going to quickly touch upon them. So first, we went into theories, trying to explain why men do not come forward, why men come forward. I think like Zach said, there are men who are quite good, they come forward and they share a lot about why they are doing so well in terms of health. But there are also this group of men who do not come forward, which we are trying to reach out to. So we did a review, trying to explore even more. We also get some ICT development theories to make our app user-centered as well as good in terms of UX and UI. Okay, UX, UI means user experience and user interface. So besides theories, we went to look into evidence, what works, what do not work. Okay, and most importantly, we also advocate evidence-based comprehensive screening, not just targeting 1 or 2 diseases. Coming from primary care perspective, we want men to access everything they need to know about their health, those evidence-based screening. So we got the list, as you can see there are mainly lifestyle, cardiovascular risk, cancer. There are only 2 about cancer, communicable diseases, as well as mental health, which is really important to reach out to the men out there. So we went down into the field as well to interview, I think more than 30 men to find out, to explore more about their behavior. In this interview, actually, we involve more of the younger group because that is the target group we are trying to reach out to. So So there are a few things that we found, and we also asked them what do they need in a mobile web app that we want to develop. So subsequently, after we got the theories, evidence, and needs, we synthesized them. There are a few development cycles going to software development now. So there are some alpha testing and beta testings. So in the beta testing itself, we asked the men, they think it's very useful, convenient to use, and preliminary data show that it increased their intention to screen. Yep, and in terms of usability, they like it because we make it very simple and fun to use, so they really like it. So after we have done the beta testing, we logged it for the RCT. So before the RCT, let's just look into what Screenmen is like. So it's actually intended to be used in mobile phone. So the main platform is actually for the phone, but it's also workable in the laptop because it's a website. Okay, so there are 3 languages. As you know, Malaysia have many ethnic group, mainly Malays, Chinese, and Indian as well. But we decided to focus on these 3 languages because these are the 3 main popular languages that Malaysians use in a normal life. Okay, so there are 4 key messages that we try to deliver to the people out there. Screen now, not when you are sick, because when we interview them, most of them do not know the proper concept of screening. When I ask them, when did you last go for screening? They say when they have heart pain, this pain and that pain, which does not reflect what screening really is, because screening is when you do it when you are still healthy, right? So there are a lot of other things that men say, but these are the 4 key messages we try to convey to men. Okay, so in Screenmen itself, actually, it's like we make it so that it feels like talking to a doctor. Okay, Dr. Screenman in this case. So we ask them a question, they answer, and then Screenman will sort of educate them about that particular disease or risk factors. So as you can see here, there's a sort of a chat feeling to it. There's a summary. Red means something that they have to do better. Green means they are already doing well. Blue are the kind of screening they need to go for. The orange are things that do not need to go for. Okay, so they can even print out a report and bring it to the doctor. So there are a lot more things that came out from the interviews, but we decided to park the rest under this 3rd module, which is the FAQs module. Okay, so just to emphasize again, we use theories and as well as meal-sensitive approach in the content of Screenmen. We always try to advocate the positive masculinity approach. Like for example, we ask them to please stay healthy to take care of the family, because we know a lot of men, they really care for the family. So we use male-sensitive concept like car maintenance, Superman-like figure, and so on, just to attract men and then increase their learnability. So there are also complex algorithms behind that provide personalized advice to men in Screenmen. And we also acknowledge that it's not one size fits all. Okay, this Screenmen cater mainly for social economy, lower social economy group, younger men, and lower educational group as well. So there are a lot more link out for the people who wants to know more. But we make it really simple. Initial version was more packed with information, but as we go along, we have to like cut it out, cut it down, cut it up, just to tailor for this group of people. And we acknowledge that Screenman itself may or may not make men go for screening. And we really think that a multifaceted approach is even better. For example, the Social Security program I've informed you just now, if they couple with Screenman, it probably can push men to come forward better. With the free screening and some education, it might make men come forward more. So in terms of RCT, we actually run an RCT over Facebook. It's fully automated. So just to share some of the results, there are 2 arms: intervention, screening, Screenman, control, get nothing. So in brief, he managed to increase the knowledge in men immediate 1 month later and 3 months later, and significant effect on the intention to screen. Men in the Screenman group says that, okay, in the next 6 months, I'm going to go for screening. But for the control group, perhaps in the next 12 months. So in terms of intention to screen, there's a difference. So last but not least is the screening uptake itself. At 3 months, we see some effect. There's a difference between the control and intervention group. Besides social media, we are also implementing it in our public health clinic. I think Joe, our colleague, is trying to do some implementation study in the public health clinic. There are 3 that he's approached. He has interviewed doctors, nurses, even patients about this implementation. So a lot of people like the idea because just like Michael's project, you know, in the waiting area is the best opportunity to teach men or educate men about anything we think relevant. So they even men say that no one, the doctors, in this case, the doctors say that it's really fitting because this is hospital, this is clinic, it's where men supposed to learn about health. And it's very simple and very fast. And then looking at what men say is actually, yeah, that's right. Nobody taught me about all this because usually in the public health clinic, men only have 10 minutes to see the doctor. The doctor have no time to really teach them everything, all the details about their health. So it's a good supplement tool for the doctor. So just also to share, in terms of strategy, Joe has 3 mechanisms: bunting, poster, and postcard passed to the patient by the doctors. It seems that the bunting placed in the waiting area has more entry as compared to the rest. Okay, this is just a pilot study by Joe. So I just shared with you all the stages, okay? And in summary, I really want to say that digital health intervention are well received by the people as well as the doctors, and it may play an important role. And I think really online is where men are. There are a lot of men out there we can reach out to because for them it's a safe environment to discuss about health. Okay. Okay. Last slide, sorry, Anthony.
All right.
Yeah, I've gone through this as well, the Delivering Men's Health report. I think it's really in line, and all the parts we have followed the guidance that you have put up. All of your work, I think we have followed very well, and it works. Okay, we have also developed this to train people, the doctors, about prostate cancer screening, because what we found is that not just people, the doctors need to be trained about men's health too.
Yeah.
Okay. Thank you. Sorry, overshot.
Yeah. No, look, thank you so much. We know how hard it is to keep, you know, all the exciting work that we're all doing to just 10 minutes. But thank you so much, Chinhei. We can see you have this passion for this, and it's so exciting to see, you know, a real life example that's applying so much of the things that we've all been talking about for so long. And that simple insight of going to where men are, even if it's digitally, is so important. And people still treat that as a revelation when you say go to where men are if you want to work with men. So thank you so much. There's been some interest and chats happening, and we'll return to this when we in the question and answer. But now I'd like to introduce people to Kira Fortune. Kira has worked for more than 2 decades in the international sphere, and she's currently coordinator of the social determinants of health and the violence and injury prevention within the World Health Organization, based at Western Pacific Regional Office in Manila in the Philippines. Kira has extensive experience in the development of global partnerships, partnerships that are committed to equity and leaving no one behind, multi-sectorial collaboration, policies and programs. So you can see our excitement in having this conversation with Kira about men's health and men's health in the Western Pacific region. So thank you and welcome, Kira.
Thank you so much. And I am having a little bit of tech trouble here. I don't know if you can see my screen.
We can see your screen, yes.
We just need to get it on slide, right? On slideshow. Yep. Does that work?
Done, perfect.
Fantastic. So good afternoon, colleagues here from Manila, and thank you so much for the invitation to this really, really timely discussion. As was just said, I'm Kira Fortune, and I'm the coordinator for the unit on the social determinants of health and violence and injury prevention. But I am, of course, here with my team. I am merely the voice today. We are a big team, and everyone is connected here today. So again, just really want to recognize that. But what I'm going to do over the next 10 minutes is that I'm going to be speaking to the social determinants of men's health here in the Western Pacific region, and then highlight some of the work that we are doing and also showcase what the countries are doing. So let me start by saying that the Western Pacific region, of course, is a very diverse region. We are home to 1.9 billion people. That is more than 1/4 of the world's population. And here in the regional office, we are responsible for 37 countries and areas. It's also worth noting that the region has one of the largest and fastest growing aging populations in the world, with over 240 million older people. Now, we all know that 2015 was a very historic year, because that, of course, is when the global community concluded the Millennium Development Goals and also adopted the Sustainable Development Goals. And I think here in the region, there was much to celebrate. We saw an increase in life expectancy. We saw a decrease in extreme poverty, and we also saw a decrease in under 5 mortality. At the same time, it's also worth noting that not everybody benefited equally from this progress. And I think that inequity and poverty continue to be some of the biggest challenge that we have in this century. And that, of course, has been further exacerbated because of COVID-19. So I think that's worth bearing in mind. And when, of course, we speak about inequities, we are very mindful of the fact that we cannot just speak about inequities between countries, but also within countries. And that is, of course, very important when we look at this region, because it's a very diverse region. And let me just see if I can, there you go. Now we know that health impact men and women very differently. And as I said, I think there was much to celebrate here in the region when we took stock of progress. And here you will see that labor force participation rates for men aged 15 and above are consistently higher than for women in every country in this region. Men's average earnings can be up to 4 times higher than those of women, and literacy rates here in the region are higher in men than in women. Men are also, at this point in time, more represented in national parliaments and in decision-making positions than their female counterparts. Having said that, we know that despite this, men also experience differences in health and have unmet needs. Again, here in the region, approximately 1.3 million men between the ages of 20 and 54 lose their life every year due to, or lose their lives every year prematurely. In this region, we also see that men are disproportionately impacted by infectious diseases, such as that of TB and HIV. And as we've seen earlier, men are at 16% increased risk of committing suicide than women. Our team is also working in the area of violence and injury prevention. And we know that data shows that men are 5 times more at risk than women to die from road traffic injuries. And then finally, I also want to just highlight some of the latest data that shows that men are 10 times more likely to die from unintentional poisoning. And finally, they are 8 times more likely to die as a result of homicide. As I said earlier, it's also really important that we're very mindful of the fact that when we address health inequities, that these are just not addressed between countries, but also within countries. And health outcomes of men can, of course, vary very much on geographic location, age, socioeconomic status, and other social stratifiers. We saw earlier on in the first presentation that ethnicity matters. In 2012, life expectancy amongst indigenous males was more than 10 years lower than for non-indigenous males in Australia. And if we take a look at Papua New Guinea, in the province of Sandown, the life expectancy there is at approximately 54 years of age, whereas in Hong Kong, it's that of 82.9 years. So that's a gap of 28.5 years within the same region. So again, this is for us to bear in mind. And as I continue to talk about how we, the strategies that we have to address these inequities. Now, I mentioned that 2015 was a historic year. If that was a historic year, 2018 for this region was also very historic, because that is the year where our member states, they adopted a 5-year strategy for the future. This future is aligned with the Global Plan of Action, the GPW13, which is the Global WHO plan for 5 years. And in this, for the future, we have 4 key priorities, 4 thematic key priorities, namely that of NCDs and aging, reaching the unreached, health security, and AMR, as well as that of climate change and environmental health. What is very unique about For the Future is some member states have also agreed to ensure that we use a gender and equity lens in all that we do. And if you take a look at the strategy, you will also see that we have set out 7 lines of action to ensure that we meet that mission in terms of realizing this. And I was very pleased to see the previous presentation in terms of the 10 actions to really address men's health, because I think there are a lot of similarities there. We really need to ensure that we understand the data, the disaggregated data. We need to ensure that we hear the voices from the ground if we are to really establish meaningful policy. And this is just to mention a few. I should also say that part of this strategy is we have sort of 3 key objectives. One of them is to ensure that all staff here in the Western Pacific Regional Office, that they use that gender and equity lens in all that we do, both in terms of our planning, in terms of our technical work, and also to ensure that we better understand the situation on the ground so that we can better tailor our policies. A second objective is to ensure that our member states, they mimic this strategy, that they are inspired by this strategy, and that they can see the advantage of really ensuring that we better understand men and boys' reality, as well as that of women and girls' reality. So again, that we can tailor our policies and our approaches. And then thirdly, and a much more ambitious goal is, and a long-term goal is to ensure that we transform society so that addressing gender inequalities, addressing men's health, addressing women's health become the norm. And that, of course, is quite a tall task. Now, again, you will see that in For the Future, we also speak about the need to really have grounds-up solutions, that is to better understand the situation on the ground. Just to sort of give you an example, I'm not going to go into great detail here, but we always like to sort of highlight Marco's story. Marco is a little boy living here in the north of Manila, where we are based. And what's very characteristic of Marco's story is that throughout his life, the social determinants of health really impact the way in which he seeks healthcare behavior. At the same time, Marco has also experienced a number of inequities that have accumulated throughout his lifetime that will impact the way in which he enters into older adulthood. And thirdly, what's important here is that Marco has been in touch with the health system on a number of occasions, but every time he has been sent back to the environment that have made him sick in the first place. So again, Marco's story is a story that we really have at the forefront of our work, because this is reminding us of how we better, again, tailor our policies, what our strategies should be. And again, we're spending a lot of time thinking about what is the kind of future that we would like to see Marco have. And the future that we are really envisaging and sort of working towards is really a life where Marco, he can live in a safe home, where he has access to TB vaccines, and where he's also socially encouraged and financially supported to seek early care for some of those health issues that he will experience throughout the lifetime. So this is just to show the numbers behind, show the faces behind these numbers that we sometimes refer to. I would say that here in the region, we are seeing that some countries are taking steps to really address men's health through national strategies. And here we have highlighted just a few. Malaysia, they have established a men's health action plan, which is again a 5-year plan. Australia, they have established a national men's strategy with a key focus on those that are most vulnerable. And here in the Philippines, we are also seeing steps towards the establishment of a national policy and strategic framework that entails really including men. And in the Cook Islands, clinics that are male friendly have been established in an attempt to really address those specific needs of men. Again, this is just a snapshot, and I will speak to this a little later, but we are very fortunate to be working with the Global Action on Men's Health to again really look at these different national policies. And because this is something that we are really looking to learn from as well, we are taking great pride in really documenting the lessons learned from these policies so that we can share that with countries within the region. Now, I just want to go back to a little bit to the story of Marcos. We know that there are very strategic entry points for us to act, and that's also what we are, of course, learning from those different policies and programs from the countries here in the region. We know that we have to act early in terms of really honing in on early childhood development, where there is an opportunity to also, again, think about developing trust with the health system, but again, also address gender norms. We know that adolescencehood is also a key entry point because young men go through a range of development and physical and other changes in their environment, making them increasingly influenced by peers, and which also affects their behavior in terms of risk-taking. And again, adulthood is another entry point for us where we know, and where we have also seen here with COVID-19, how men are becoming more vulnerable due to unemployment as well as that of financial stress. And then, of course, we are also investing heavily in aging because this is the fastest aging region in the world. And we know that older men are experiencing a significant burden of disease, in particular represented by chronic illness such as heart disease, respiratory illnesses, and cancer, just to name a few. So what we are looking at is really trying to work with colleagues in different areas and really honing in on those different entry points to, again, we know that that's where we can make a real impact in terms of change. Oh, excellent. So let me just speak to very briefly as to what we are working on here in the region. As I said, we have been tasked with really ensuring that all of us, both in the regional office, but also in the country office, really apply that gender and equity lens. And that has entailed a number of strategic dialogues across the organization as a whole, really looking at the very practical steps that we can take, really looking at what are the different lived experiences of men, of boys, of women, and of girls, and how can we again best tailor our approach to the work that we do and address those different barriers that men and women they face in accessing healthcare, but also in terms of risk-taking behavior. We also have the grand privilege of working with the Global Action on Men's Health. We're currently developing a strategy paper. We have just come out of our regional committee meeting where we took stock of, we are now 3 years into implementing our 5-year plan. We took stock, and there was a recognition that, again, we need to have better strategies for women's health and better strategies for men's health, because again, they experience health very differently. And this is now an opportunity to really take stock of the progress here in the region, but also to better understand the data, better understand the evidence, and better understand how we, again, develop strategies that are effective in terms of addressing men's health. Over the past 2 years, we have also been collecting data and evidence on men, women, boys and girls health here in the region. And we are planning to launch that next year. We're working with our colleagues in health information and data, and all this information will be integrated into the BIPRO database, so that again we have a better understanding of what the reality is on the ground and how we can best tackle some of these public health issues. We've also been working to establish a community engagement movement, and we've really found that this has been a fantastic way of really address some of these issues that we are addressing today. Working with local community leaders is a really efficient way of really understanding the realities on the ground. It's a really efficient way of understanding what are the challenges. One of the things that we have seen, for instance, is that not every community is able, for instance, to comply with WHO guidelines on COVID-19 simply because they don't have access to clean water, or they are not in a position to being able to self-isolate because they are living in a crowded housing. So again, what we found is that working hand in hand with community leaders, this is really a way to again better address men's health, boys' health, women's health, and girls' health, and also really again thinking about what are some of those more localized community solutions that the community have, if you like, in terms of local knowledge. Now, these are just a snapshot in terms of what we're doing. You know, it is work in progress. We recognize that. But we are also increasingly being asked by our member states to ensure that we have this more tailored approach, and that we have a much more nuanced understanding of what men's lived realities are. And so just on a final note, this is of course I'm really having trouble with my, oh, here you go. So just on that very, very final note, again, this is a task that we have been asked by our senior management. It's not just myself and my team, it really is an institutional responsibility. And again, we are working with every technical area, but also every admin area to make sure that we, again, mainstream gender, and understanding that that means including everyone, including men, including women, including boys, and including girls. And we are excited to, again, make this a reality. As I said, it is work in progress, but we have set this very ambitious target of ensuring that we do transform societies in the long term. And I'm very excited to be part of this forum today, because that is a journey, and it's a journey that we can't be on our own. We really need to partner up with people like yourselves who have all the experience and know-how. On that note, I will stop here. Thank you so much.
Thank you so much, Kira. We're also excited to be on this journey with you. It's one of the reasons why Global Action formed was because we really wanted to help influence World Health Organization and other sort of global leaders around having men's health on their agenda. So it's really exciting for us to be involved in the conversation and to be at the table. One of the great things that Global Action offers is the diversity of our members. We have members who are organizations that are working with men and boys in different countries. We have academics and practitioners and community leaders. So we hope we can help make those introductions. And one of the things that I think was really striking for me that came out of Kira's presentation as well was, for a long time, some of us have been talking about the importance of the social determinants of men's health and how those factors, those social and environmental factors, impact on the health of boys and have a cumulative effect of men across the lifespan. So it's wonderful to see that. Of course, today's webinar, we've mainly been talking about how we can make health services better for men, which is vital. But if we're making health services better and we're still and men are going back into environments that aren't good for their health, social and physical environments that aren't good for their health, well then, you know, what we do in health services can only ever be part of the solution. So thanks for reminding us about that, Kira. And I'd also like to, so now I'd like to welcome our final speaker, someone who is well known to most people on the webinar. Peter Baker is Director of Global Action on Men's Health. Many people will also know Peter for his work in advocating for a gender-neutral approach for vaccinations for HPV, which we're really excited to support. And of course, in his former role as the former CEO of the Men's Health Forum of in the UK. So thank you and welcome, Peter.
Thanks, Anthony, and good morning, everybody. It's great to be here. I'm speaking to you from the United Kingdom, where it's just after 7 o'clock in the morning. So it's an early start, but this has been well worth getting up for. So I'm absolutely delighted to be here and to have this opportunity to talk to you about our work on delivering men's health. As I hope some of you already know, this report, Delivering Men's Health, was published back in September, and it's accompanied by a database which we've developed jointly with the Men's Health Information and Resource Centre at the University of Western Sydney. And the database is hosted on the MENGAGE website. And you can see the links there, both to the report and to the database. So if you haven't already seen these, please do take a look. And with the database, it's very much a work in progress. So please help us to keep that up to date. And if you have any ideas for a material that could be added to the database, please do let us know. Why did we do this? Why did we produce the Delivering Men's Health report and database? Well, the reasons are, I'm sure, obvious to most or all of you. Clearly, men's health at all levels, globally, nationally and locally, is far poorer than it could or should be. And globally, average male life expectancy is still just 71 years. And there are major variations in health outcomes for men and boys between and within countries. And as we know, income and race are two key factors that impact on male health. And the COVID-19 pandemic has hit men particularly hard, and globally has accounted for about 60% of all deaths. Over 2.5 million men worldwide had died by August. And in fact, we now are pretty certain that over 3 million men around the world have died as a direct result of the COVID pandemic. We're also pretty sure that if systematic action had been taken to improve male health before the pandemic, its impact would have been far less acute. It's pretty clear that the extent of underlying disease in men, problems like lung disease, diabetes, cardiovascular disease, hypertension, and so on, have contributed hugely to male mortality. And if action had been taken to deal with those problems sooner, then COVID wouldn't have had the impact that it did, and is still having, of course. And we know that a male-targeted response is essential to these problems. It's not only ethically right that we have a focus on men as well as women, but we also know that improving men's health would save money. It would be good for not only expenditure on health services, but also it would reduce employers' costs and have other wider economic benefits. And it will be good for women's and children's health as well. Clearly, there have been some calls for action on men's health by the WHO, and it's fantastic to hear what Kira's been saying about the work of the Western Pacific region. And we know that the European WHO region and the WHO region for the Americas have been doing some great work on men's health. But overall, I think it's still fair to say that the delivery of men's health policies and programs around the world has been very limited and patchy at all levels. And part of the reason for that, I think, is, I mean, there are many reasons for this, but one reason is that a lot of people working in the field, in the health field generally, don't really know what to do when it comes to men's health. We, as advocates in this area, often complain that action isn't being taken, that people aren't doing enough, and that's obviously true. But at the same time, unless people understand what they can do to be effective, it's very hard to expect them to do very much. So we think it's very important that we provide information and guidance to policymakers and service providers and practitioners about how they can engage with men much more effectively. And that's why we developed Delivering Men's Health. The report covers 10, we could have produced 30, 40 or more ways to improve men's health, but to make the resource manageable and usable, we tried to focus these down into 10 key ways, 10 key things that people can do to take action to improve men's health. And I won't go through them all. You've already seen this list from a previous presentation, but you can see that these are 10 key things, 10 key steps that people working in the health field can take to improve men's health. And I'm going to, for each of the 10 ways, we highlight 3 main things in the report. There's a key message, top tips, and case studies. And I'll just talk about one of them. One of the key ways, one of the 10, is meet men where they are. And again, we've heard reference to this already. And the key message here is develop outreach services that engage men where they are. And here are some of the top tips in this section. Identify where there are significant numbers of men who are in need of health support. Examples of places of where men are can include workplaces, community venues, sports settings, faith organisations, and online. It's important to develop partnerships with organisations operating in these locations with a view to delivering interventions jointly. And it's very important to consult with men in the target group and to co-design interventions with them. They're much more likely to be effective if we approach work in that way. It's important to be imaginative. Even seemingly unlikely settings can prove effective. And we've seen examples of men's health checks delivered in pubs, for example, at horse race courses, and in do-it-yourself store car parks. So I think we need to think outside the box when we're thinking about where we can take services to men where they're likely to be used. It's important, of course, to ensure that interventions are monitored and evaluated, and to plan for sustainability so that successful services continue once the initial funding has run out. And I think it's also important to take the learning from these kind of services, these kind of outreach services with men, and see where we can use that learning in the development of mainstream services, because outreach services on their own are never going to be enough. We have to change the way that mainstream services are delivered as well. The report contains a number of case studies which illustrate the different kinds of settings where this work can be done. So, for example, we highlight Football Fans in Training, which is a program in Scotland which used sports stadia. It was delivered in sports stadia. It's around weight management, diet and physical activity. Power Play in Canada is a workplace initiative. Barbershops have been used in a number of countries in the States and the UK and probably elsewhere to deliver a range of different services for men, some around mental health, for example, and some on hypertension and prostate health. Men's Health Champions. In the UK, there's recently been training work delivered by a county council and also by the Men's Health Forum to train up community men's health champions who can have conversations with men about health in the workplace, community venues, and elsewhere. Men's Sheds have emerged as a very important community venue, particularly for reaching older men. And there are examples also, and we've heard one already today, Screenmen, but also Quit Now Men. These are online services which have been effective working with men in cyberspace. Quit Now Men, as you may have guessed, is around smoking cessation. So what are we going to do next in this area? Well, we want to continue to disseminate the Delivering Men's Health resource to make sure that as many people working in the mainstream health services get access to this and find out about it. We want to continue to develop the database, as I've said, and we welcome your help with that. We hope next year to start to develop a training program which we can use to skill up policymakers and practitioners around the world to use based on the ideas in the resource. And we want to work with partners to implement the guidance, to basically find policymakers and practitioners, service providers who are willing to work with us, as we're now doing in the Western Pacific, I'm pleased to say, with the WHO, to see how we can actually use the ideas in there to change policy and practice. I just want to finish, this will take 1 minute of your time, to share a video, which I think is a very good example of another of the 10 ways, which is being positive about men. We often talk about the need to be positive about men. We actually, I think, find this quite hard to do. We tend to slip into being, critical of men for not looking after their health better, not seeking help, and so on. And I think it's really important that the work that we do builds on men's strengths and takes a positive view of men and masculinity. And I think this very short video from Prostate Cancer UK illustrates one way that we can do this. So I'll just play this to finish my presentation.
What a piece of work is a man. How noble in reason. How infinite in faculty. In form and moving. How express and admirable.
Wow,
in action, how like an angel. In apprehension, how like a god. The beauty of the world, the paragon of animals.
I love you, man.
And yet, to me, what is this quintessence of dust?
Okay, thanks very much. Now we can move on to an open discussion, Anthony.
Yes, thank you so much, Peter. And thank you for ending with that great video and reminding us all about the importance of those positive approaches and the strengths-based approaches, which really, I think, was one of the strengths of the original Australian men's health, male health policy. Before I open up for discussion, and I am aware of time and that we, literally only have 5 minutes left for discussion, I do want to let people know that the links to the report that Peter has been talking about is in the chat, as is the link to the database for MENGAGE. Glenn from the Australian Men's Health Forum has also put in a link. Thank you, Glenn, for the Australian Men's Health Forum's guide to developing male-friendly services. And I'd also let people know that the database has practitioners' guides for working with men as well, for working with men in health promotion, in mental health, and with men as fathers. So encourage people to explore the database to look for those, and also to let us know about the work that you're doing that we can add to the database. There's been some questions that have come up as we've gone along, and I think one of the themes that's come up has been about talking to men and talking about men's lived reality, and something that I think in men's health maybe we've been a bit slow to engage with. Zach was the first person to mention that, and Zach, I'd value your views in some ideas about where's a good starting point for us to help with that.
I think the really interesting thing is the stereotype that men don't want to take part in this work. The thing that I learned last year, as I said, with that survey, was that we put it out there. We offered no money for this survey, and we got 2,000 men in a fortnight responding to a 20-minute survey. And we actually built in a question that we're now reviewing, because I'd like to do some work in how to actually, firstly, engage men in research work, let alone in service provision, creation, and that type of thing. But we had this question that looked into altruism and looked into why men take part in this stuff and how to actually derive an understanding from the guys to then package up something. I think our marketing, full stop, around men's health has failed miserably for a very long time. I think that Movember, not to toot our own horn, I didn't create the brand, has done a very good job at trying to, get men in. It's, we always talk about health by stealth. And I think that Movember has managed to do that just by being a bit of a, gimmick for a very long time, and everyone just comes on board, and then they end up having meaningful conversations, for instance. So I think that really it is a matter of trying to understand by going out to groups of men and diverse groups of men in that to understand what do they need, what are the levers here that are going to get them involved, and for them to see. I think it's something that we're dealing with when it comes to climate change, when it comes to feminism. How do you get men to give a crap really about their own well-being before crisis hits, and understanding that proactive rather than reactive health provision is the way forward. So there's just been a long period, I think, in many ways, of speaking to small groups of men, and if we can expand that to try to understand what are the best ways to engage them, and why should they care is something that we should be asking a lot, and how to bring them in on this work so that they feel invested, which is what I do as a therapist as well, which is, this isn't for me, this is for you and your family, and let's really make that clear and empowering, full stop, as well.
No, thank you, Zach. I think that's quite insightful there. And I'd actually like to draw Michael into the conversation and ask about the starting point for our webinar today was your work and looking what is and isn't in waiting rooms, and how do we bring some of the discussions and insights that we're learning in other areas of health services, how do we bring that into health promotion as a starting point to get out to men?
I've got to say, I agree with Zach and the health by stealth. At St Vincent's, we're taking a different approach by having a bricks and mortar men's health centre constructed at the moment. We have seen the utility of health promotions through virtual channels and through other digital means. We are trying an approach where we'll merge those two, but we'll have a centre funded by philanthropists on a prominent street in Sydney, right near Oxford Street, heart of the CBD, that will have Men's Health Centre bang on the front. And we'll start that conversation at a street level. So we will have our clinicians working in different areas to promote health, both to regional and rural communities. But our partners here are telling us they want to see men's health. They want to see an actual building. They want to see iconography. They want to get that message normalised. So I agree with every single speaker today that normalising conversation is paramount, and we're going to take the approach of being quite overt in the CBD and then spreading that throughout.
Thanks, Michael. We had an interesting comment from Alan about men's often when there are health promotion material, men don't always engage with it. and reminded of quite a few years ago, Cancer Council in Australia produced a wonderful series of men and cancer resources where the actual health information didn't vary from other resources, and they weren't talking about male-specific conditions, but through colour and imagery, we're able to engage so much better. Look, I am very aware of time and that we were trying to finish up at 6:30, and we've had some great questions, including questions about a lack of research and services in the region for men who are survivors of sexual abuse. A big issue and something we could probably do, a whole webinar on, as well as some suggestions around how men can engage or don't engage with surveys, and then the outreach that people have done, and what we've learned from sheds and other things that have engaged men successfully. But I had a question for Kira, in terms of, we've got men from across the region and services and organisations across the region, on this call now, and also and elsewhere in the world, of course, but also through our membership. What are some of the networks or things we can do to better support the work that the region is doing, and also to help develop policy and projects that are responding to men's needs and to the needs of different groups of men?
Yeah, so thank you so much, Anthony. And I think you actually addressed it earlier on when you said that this network here, of course, has access to a lot of other networks. And I think that is really where we should be joining forces. We, in our work, need to be, as I said, much better at listening to the voices on the ground. We are really looking to really contextualize the work that we do. So in that sense, I think, and as I said, we have been, as part of the COVID-19 response, we've really been honing in on community engagement, understanding that this cannot just be an emergency response, but it needs to have a sustainable life of its own. So we're really building that movement. And part of that is, we have three core priorities. One of them is to again, strengthen and build partnerships, not just in the health sector, but also beyond. Is really investing in those local governance mechanisms. As I spoke to the sort of strength of our community leaders, we have wonderful mechanisms in this region that we can, again, really sort of tap into. And then it's also to work with community volunteers, because the community volunteers, they play an instrumental role in terms of, again, gathering the qualitative as well as the quantitative data. So it's really working with the community as a whole. And I think that's where we can join forces, because you have access to network, you have key knowledge that would really benefit our work and the way, as I said, we tailor our policies. We are so aware of the importance of really tailoring our policies, precisely because we work in such a diverse region. So for us, it's a real pleasure to be working with you. And I think the strategy paper that we are currently working on will, that's going to pave the way, if you like, in terms of moving this work forward.
Thank you, Kira. And as I said, we're really excited to be part of this. Look, I can see some people are already leaving, and we do understand we did say we'd finish after 90 minutes. But I did have one final question that I wanted to ask Chin Hai, and that was, with your exciting work with Screenmen and you moving into that digital space and health promotion digitally, well, what are some of the lessons you think those of us working with men's health could take away from this work and apply to other areas of working with men?
Thanks, Anthony. And just taking the vaccination as an example for the COVID-19, I think the social media online platform has done a great work, because it sort of removed the stigma And when someone posted, hey, I've done my jab, what about you? So it creates the ripple. It makes more men go, men or women. It motivates everyone to go for the vaccination. So looking at the vaccination example, I'm thinking about screening itself. Perhaps some kind of ripples created by someone in the social media could actually bring up, or even beyond screening, could improve health promotion work that we are so far trying to do, which hasn't been quite well done. So I think online is a good platform to really push people using the social power, reach out to everyone, and then push people towards health promotion better. That's what I think I've learned so far.
Thank you so much, and I think there's lots we can take on board from that, and think about how we can apply those lessons. So look, we will finish up, and I'm sorry we haven't been able to get to all the questions. Great and really important questions coming up about violence and violence against children and boys, and what sort of exposure to violence means to boys as they're growing up. So as I said, sorry that we can't get to all of those important questions. We have gone over time. Peter, is there anything, any last words to sort of before we close off and finish for the evening?
No, I think we have to wrap up, Anthony, but thank you very much for everybody. Thank you to the presenters for making some excellent presentations, and thank you to you, Anthony, for chairing so brilliantly as usual. I think it's been a really interesting webinar, and we'll be posting the recording of this on our YouTube channel as soon as we can, and I will make sure that everybody who registered to attend gets sent the link. And we'll also share again the URLs for the report and the database. But thanks very much, everybody.
Thank you, Peter. Thank you to all our presenters. Thanks for the great engagement and discussions in the chat. We will be holding more men's health webinars in 2022, so stay tuned. And thank you for your time. And for everyone, I know it's this early in the UK, so thank you to the colleagues there for joining us. And we look forward to seeing you later, and have yeah, a wonderful evening, a wonderful day, depending on where in the world you are, and look forward to catching up with you in 2022. Thank you all.
Thank you. Bye-bye.
Bye.
Bye.